Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. So today we're going to discuss gas exchange and VQ part 3. So this is the Great Adventure. So today we're going to talk about a few kind of interesting things about gas exchange. So absorption and atelectasis. So nitrogen is a gas that we've not yet mentioned, yet it comprises 79% of gas in the lungs. So in normal resting man, nitrogen is neither excreted nor absorbed in each breath. So the nitrogen you inhale is the nitrogen you exhale. So this stabilizes lung volume. So even if all oxygen is removed from an alveolus, nitrogen remains, and thus you should, at least theoretically, be left with about 80% of alveolar lung volume, and the alveolus will not collapse. So nitrogen can be viewed as a stabilizing influence on alveoli. But is this true? So here we have an example of um, atelectasis, and you can see right middle lobe atelectasis here. That's a completely collapsed lobe. Atelectasis generally occurs with complete airway obstruction. So if the obstruction is complete both during inspiration and expiration, then air is, as you'll see, absorbed distal to the obstruction, causing collapse. So atelectasis is commonly due to airway obstruction. Gas trapped beyond the point of airway closure is absorbed by the pulmonary circulation. Total partial pressures of gas in mixed venous blood is less, that is the total, is less than in the alveolus. Thus, gas will move along pressure gradients from the alveolus to venous blood. So here we have while breathing room air and while breathing 100% oxygen. So PO2 in the alveolus we know is 100, arteries is about 100, and in the vein is about 40. CO2 40, 40, and 46, a little bit higher in the vein. Nitrogen is about the same across the board if you're breathing room air. But if you breathe 100% oxygen, things change slightly differently. There's a huge gradient between the alveolus and the vein. CO2, again, no change. Nitrogen, there really isn't anything if you're breathing 100% oxygen. What happens? If you're breathing 100% oxygen prior to airway occlusion, then alveoli contain only oxygen, CO2, and water. CO2 plus water are usually less than 100 torr, so the alveolar oxygen must be greater than 600 torr. Mixed venous PO2 is less than 50 torr, and therefore alveolar minus venous O2 gradient will be greater than about 550. Alveolar collapse will be rapid as there is no nitrogen to maintain inflation. Okay, so that's complete airway closure, breathing 100% oxygen prior to closure. Breathing 21% oxygen prior to closure. So initially, alveolar nitrogen is less than mixed venous nitrogen. However, PO2, or oxygen, the PaO2 alveolar is much greater than mixed venous, so oxygen will be rapidly absorbed. Then nitrogen PO2 will become greater than mixed venous, and nitrogen will be absorbed also. Thus, absorption atelectasis can occur behind airway closure, even with nitrogen comprising 80% of air, though it will take longer. Can you get absorption atelectasis if airways are not completely occluded? So alveolar stability occurs when there is as much gas coming into an alveolus as being removed. Conversely, atelectasis, or alveolar collapse, occurs when the amount of gas removed from an alveolus exceeds the amount coming in. So absorption atelectasis can occur in the absence of total airway occlusion if the VQ ratio is sufficiently reduced. If the regional VQ ratio is less than 0.05, not 0.5, 0.05, even breathing 100% oxygen cannot supply as much oxygen to the alveolus as is being removed, so alveolar collapse can occur. Some COPD patients have regional VQ profiles or ratios less than 0.05. And this just shows an example here in normal subjects, actually, of EQ profiles breathing room air or breathing 100% oxygen. You can see that a young normal subject is unlikely to have much lung with VQ that low, but a normal subject in the 40s, all right, can have VQ ratios less than 0.01 if breathing 100% oxygen. Not quite so bad if breathing room air. So this can occur even in normal subjects. So at VQ ratios less than 0.05, the critical P-alveolar O2 required to prevent atelectasis decreases. So the lower the regional VQ, the lower the FiO2 where collapse can occur. At a VQ ratio of 0.001, absorption atelectasis can occur breathing even room air. So this is depicted here. All right. So what we've plotted on this axis is fraction of inspired oxygen, and what we have plotted here is VQ ratio. Note we're starting very low, 0.1, 0.04, etc., down to 0.001. So below this blue line, alveoli are stable. That is, they do not collapse. But above this blue line, alveoli are unstable and liable to collapse. So, for example, if you're breathing 100% oxygen and you have a VQ ratio less than about 0.05 maybe, you can get alveolar collapse. All right. If you are breathing some nitrogen, okay, not 100% oxygen, then the VQ at which collapse occurs becomes lower. And finally, if you get a VQ ratio as low as 0.001, even breathing room air, alveoli are stable and liable to collapse. That is, you're going to remove more oxygen than is coming in. Distal to the airway closure, all right, absorption atelectasis occurs rapidly breathing an FiO2 of 100%. It can occur breathing room air, that is a FiO2 of 21, though more slowly. And it can occur at any FiO2, but it takes longer to occur the lower the FiO2. So decreasing FiO2 does not reduce the amount of absorption atelectasis. That is, it can still occur with a sufficiently low VQ, even breathing room air with an FiO2 of 21%. What about incomplete airway closure? Absorption atelectasis can occur if alveolar gas is removed faster than it's replaced. So again, this is dependent on a sufficiently low VQ. The lower the regional VQ, the lower the FiO2 where collapse can occur. At a VQ of less than 0.01, absorption atelectasis can occur breathing room air with an FiO2 of 21%. So VQ is more dependent at determining absorption atelectasis than FiO2. They're both important, but you can override any nitrogen at a sufficiently low VQ. Okay, pneumothorax. So here, obviously, we have a pneumothorax. So it's an abnormal air leak into the pleural space, often requires needle aspiration or a chest tube. Supplemental oxygen breathing may be useful for a small pneumothorax, but how does this work? If we look now at pleural oxygen, CO2, nitrogen, arterial and venous, while breathing room air, you can see that if you have an air leak, it's basically going to be inspired PiO2. It's going to have PO2 of 150, PCO2 of 0. Okay. In the artery, ordinarily you have a PO2 of 100 and a PCO2 of 40. All right. And in mixed venous blood, PO2 of 40 and a PCO2 of 46. Nitrogen here is about the same across the board. And remember, nitrogen is 80% of your volume of gas. So there's not going to be much movement here. I mean, yes, some oxygen might be reabsorbed, CO2 won't, and nitrogen probably won't. However, if you breathe 100% oxygen, okay, now, at least initially, that pleural PO2 is room air that came in. This is not 100% oxygen, okay? CO2 is 0, all right? Arterial O2 is now 600, but venous O2 is still 50. So you now have a pleural gradient, a gradient here of pleural O2 to venous O2. So pleural O2 is going to move into the venous system. All right. CO2, not much change, But nitrogen, look at this. So nitrogen, the plural PN2 is 563. It's zero in artery or venous. So there's going to be a huge gradient where nitrogen will move into the vein and consequently reduce the volume of gas. So we can actually picture this, all right? So breathing room air, oxygen, yes, some of that oxygen will go into venous blood. CO2, no difference, and nitrogen, no difference. So O2 goes from the pneumothorax to venous blood, but nitrogen doesn't. If you breathe 100% oxygen, you now have a gradient for oxygen, and most importantly, a huge gradient for nitrogen. So now oxygen goes from the pneumothorax to venous blood, and nitrogen goes from the pneumothorax to venous blood. And this is what's really responsible for reducing the volume of the pneumothorax. So assuming there's no continuing air leak, okay, assuming there's no continuing air leak, breathing FiO2 100 or 100% facilitates absorption of nitrogen, of oxygen and nitrogen from the pneumothorax to venous blood. It does not alter the pneumothorax PO2 or PN2, but it decreases venous nitrogen PN2, that is, creating a nitrogen pressure gradient from the pneumothorax to venous blood. So that's how that works. It's primarily by reducing the venous nitrogen, so there's now a huge gradient from the pneumothorax to venous blood. All right, calculating P alveolar and O2 and CO2. So let's consider a case. A 17-year-old anxious girl with a psychiatric history is being treated for a urinary tract infection with an IV penicillin. She is hyperventilating and in respiratory distress. It's an acute onset. I was called to see her. It's a true story. And she was quite distressed. We did a blood gas and her PCO2 was 20. So assuming a normal cardiac output of 5 liters per minute, what is her alveolar ventilation? So think about this for a second. PCO2 20, cardiac output 5. Is it 2.5 liters per minute, 5, 7.5, 10, or 20? So remember that PCO2 in this case is proportional to VQ. So if we've got a PCO2 less than 40, we know the VQ ratio is higher than 1. PCO2 is inversely proportional to alveolar ventilation. If you've got increased alveolar ventilation, you're going to get a decrease in PCO2. So we've got a PCO2 of about 20, which looks like it's right about here in this graph. So in the range of perhaps 20. But remember that PCO2 is inversely proportional to VQ and to VA. PCO2 is half normal, then the alveolar ventilation must be twice normal. So normal alveolar ventilation and cardiac output at rest are 5 liters per minute. Thus, her alveolar ventilation should be twice normal or 10 liters per minute. So that's the correct answer to the question. Assuming she has no lung disease, for her PCO2 of 20, what is her PaO2? And we have 50, 75, 100, 125, and 150. Use the alveolar air equation. Remember, this is the alveolar PO2 is oxygen in minus oxygen out. And the alveolar air equation is relevant here because her disorder is a uniform process throughout the lungs. Okay? She is hyperventilating, and that's causing problems. P alveolar O2 is PiO2 minus PCO2 over 0.8. So in her case, we have barometric pressure. We're at sea level. I should have mentioned that. So PiO2 is 150. And then for a VQ ratio of 1, we've done this before. This particular VQ ratio, right, PCO2 is half normal or 20. And then putting this in the alveolar equation, it's 150 minus 20 divided by 0.8 or 25. So the P alveolar O2 is 125. So that's just an alveolar air equation problem, and this was the correct answer. All right, again, same case. What is the most likely cause of her acute hyperventilation? And I realize this is not physiology, but that's okay. Anxiety, hysteria, illicit drugs, or penicillin. Acute and uncontrollable hyperventilation is due to substances until proven otherwise, as far as I'm concerned. Illicit drugs, CNS stimulants, must always be considered and ruled out, but her tox screen was negative. Penicillin actually is a CNS stimulant and was in fact the cause of acute hyperventilation in this girl. She was on carbenicillin. And if you look up side effects in the PDR or elsewhere, you will find listed long down, but nevertheless, that CNS stimulation and hyperventilation are potential side effects. So in this case, the most likely cause of her acute hyperventilation was her penicillin for treatment of the UTI. It was not her psychiatric disorder. So this is a member of what we call the long gray line. This is the group of pediatric pulmonary fellows trained here at Children's Hospital Los Angeles, um, who have contributed greatly throughout the years since their graduation. And this was a case that he, Hovig Artinian, and I actually saw. So when on service, we were called to see a 16-year-old male with muscular dystrophy. He was lost to pulmonary follow-up and had not been seen in over a year. He was on no pulmonary treatments or medications. He was not on ventilatory support. So he presented to our emergency department in some respiratory distress, but there was no sign of pneumonia or acute infection. A capillary blood gas in the emergency department showed pH 7.30, PCO2 85. He was breathing room air, and his O2 sat by pulse oximetry was 82%. Of course, the diagnosis here was chronic respiratory failure. He was admitted to the hospital to discuss his prognosis and decide about home mechanical ventilation or what he may or may not want to do. A bit later, the resident team noted a history of clotting in this boy, and they wondered if a pulmonary embolus could explain his hypoxia. So they called Dr. Artinian, our fellow, to ask about doing a spiral CT scan to rule out a pulmonary embolus. What advice do you give the resident physician? 1. Pulmonary embolus is likely, approve the spiral CT. 2. Pulmonary embolus is unlikely, but approve the spiral CT to be safe. 3. Hypoxia is due to pneumonia, do not approve the spiral CT. 4. Hypoxia is entirely explained by hypoventilation, do not approve the spiral CT. So these are the options for the question. So basically, what you need to do here, what you need to know here, is how to calculate the oxygen or the PiO2 or the PO2 in this patient who has a PCO2 of 85. So that again is the alveolar air equation. So PO2 equals PiO2 minus PCO2 divided by 0.8. So in our example, PiO2, this is at sea level, is 150. PCO2 was 85. 85 divided by 0.8 is 106. So his P alveolar O2 was 44. Right? Now, if we look on the oxyhemoglobin association curve, all right, a PO2 of 44 is in fact an O2 saturation of 82%. In this case, hypoxia was completely explained by hypoventilation due to his ventilatory muscle weakness. There was no need to hypothesize an additional cause of hypoxia, and after explaining the above, our pulmonary fellow had the residents cancel the spiral CT. So physiology can be useful. Hypoxia is entirely explained by hypoventilation. Do not approve the spiral CT. How much supplemental oxygen do you need? All right. A 6-year-old boy is admitted for pneumonia. Well, breathing room air, his saturation is 70%. You obtain an arterial blood gas that shows a pH of 7.5, PCO2 of 30, and PaO2, these are arterial, of 37. You want his saturation to be 95. What FiO2 do you need? 30%, 40%, 45, 50, or 60? Now this, unless you're a real whiz, is probably difficult to calculate quickly, but let's just go through it. So the first thing we want to do is see what is the PO2 that generates a saturation of 95%. And it's about 80. Right here, PO2 of 80 has a sat of about 94.5. We currently have a situation where this patient breathing room air, all right, his PCO2 is 30, he's hyperventilating some, so his alveolar oxygen tension is 112. It's 150 minus 30 divided by 0.8. But in an individual in a steady state, the P arterial O2 over P alveolar O2 ratio is constant. All right. So in room air, this particular patient has an arterial PO2 of 37 and an alveolar PO2 of 112. That's a ratio of 0.33. So obviously there's a large alveolar to arterial oxygen gradient indicating intrapulmonary disease. So remember, P inspired O2 to P arterial O2, that ratio is constant in an individual. All right. So PiO2 we know is barometric pressure minus water vapor pressure. If we look at all of these, basically PiO2 is PiO2 times barometric minus water pressure. So we can substitute this term. These cancel. So basically it's also proportional to FiO2. Okay. All right. So in this particular example, we have desired FiO2 over the actual FiO2. We have desired PaO2 over the actual PaO2. Desired is 80, actual is 37. The actual FiO2 is 21. So we can reconfigure this, solve for FiO2, and we get 45%. And that will actually give us an expected arterial O2 of about 94, a little bit higher than what we need, but nevertheless, it's in good shape. So the answer to this question is 45%. And you saw the way we calculate that. Can we estimate fraction of inspired oxygen from oxygen liter flow? This is a common question, and frankly, it's commonly done, but we'll discuss it. In a man with acute pneumonia in no distress, okay, he's breathing 15 times a minute, tidal volume 500 mLs. He requires supplemental oxygen at 5 liters by nasal cannula. What is his FiO2? Your choices are 25, 30, 35, 40, or 45. Okay? All right. So here is a typical chart of nasal cannula oxygen flow and estimated FiO2 for a normal adult, and we'll see why that's important. So basically on this graph, FiO2 increases by about 4% for each liter per minute of oxygen flow. But is this true? Is this really true? In order to calculate FiO2 from an oxygen flow rate, you need to know the oxygen provided by supplemental oxygen and by spontaneous breathing. Okay? So in this case, this individual has what's called a mean inspiratory flow rate by spontaneous breathing, which is tidal volume divided by the inspiratory time. In this case, his tidal volume is 0.5 liters. His inspiratory time, because his respiratory rate was 15, is a third of that, 1.33, and then times 60. So that's 22.6 liters per minute. Now, in all honesty, mean inspiratory flow actually underestimates the flow during inspiration, but let's just use it as a guideline. So mean inspiratory flow rates at man normally are probably between 20 and 30 liters per minute. But of the 22.6, all right, 5 liters per minute is FiO2 100%. The remainder is room air, that's 17.6. And the amount of oxygen provided by that is 17.6 times 21% or 3.7. So the total oxygen, all right, that's being delivered to this individual is 5 liters per minute from the supplemental oxygen and 3.7 liters per minute from room air that he's breathing around this nasal cannula. So the FiO2 is the total oxygen divided by the total flow. So it's 8.7 divided by 22.6 or 38.5 or 0.385. The FiO2 then is roughly 38 or 40%. We have to make a lot of assumptions. We need to know the in-story flow rate of an individual to calculate FiO2 from a given liter of supplemental oxygen, and this is not readily available in most patients. You cannot accurately estimate, therefore, you cannot accurately estimate FiO2 from oxygen liter flow alone. Now, the answer to this question was about 40%, all right? But remember, this required a lot of assumptions. Let me illustrate why this is not always true. So another man with acute pneumonia has respiratory distress and is breathing 40 times per minute at a tidal volume of 750 mLs. He requires supplemental oxygen also at 5 liters per minute by nasal cannula. How does his FiO2 compare to the man without respiratory distress? Is it the same? They're breathing the same 5 liters per minute. Is it higher? Is it lower? It depends, or you can't tell. So let's go through the exercise here. In order to calculate FiO2 from oxygen flow, you need to know oxygen provided by supplemental oxygen and by spontaneous breathing. So the mean in-story flow rate in this case, okay, is 0.75 liters divided by the in-story time of 0.5, all right, times 60 or 90 liters per minute, all right? In-story flow rate for this patient in respiratory distress is at least 4 times that of the slower breathing man. So of the 90 liters per minute total flow, 5 is 100% oxygen. The remainder is from room air, which is 85 liters per minute times 0.21 or 17.85 liters per minute. FiO2 is total oxygen divided by total flow, so this is going to be 5 plus 17.85 or 22.85 divided by 90, which is 0.254 or 25%. So the FiO2 is lower, even though the amount of supplemental oxygen is the same. Okay? So I maintain, well, again, we've made a lot of assumptions. And the problem, again, is you need to know in-story flow rate of an individual to calculate this, and we rarely have that. So you cannot, in my opinion, really estimate FiO2 from oxygen liter flow alone because FiO2 varies by the ventilatory pattern, amount of supplemental oxygen, and total flow. All right? So the answer here is that the FiO2 is lower. It's considerably lower, right? 25% versus 40% on the same 5 liters per minute. That's important. So adult charts estimate this from nasal cannula, and they're likely to be inaccurate in infants and children. Since the goal of supplemental oxygen therapy is to achieve a desired PO2 or saturation, one can really skip the intermediate step of estimating FiO2 from a given oxygen liter flow and simply measure saturation or PO2 to achieve the desired oxygen liter flow by nasal cannula. And this is what we do and what I'd recommend. There's no point going through the intermediate calculation, which, as you can see, can be quite variable even at the same level of supplemental oxygen. Right, calculating alveolar O2 at high altitude. Consider this, a 7-month-old baby girl with chronic lung disease of infancy is going on a family vacation to a ski resort at 8,000 feet elevation. While breathing room air at sea level, her saturation is 98, and her arterial blood gas is pH 7.4, PCO2 40, PO2 95. What will be her arterial O2 at 8,000 feet elevation? 50, 60, 70, 80, or 90? The first thing we need to do is we need to figure out the PiO2. Now remember that at altitude, it's the total barometric pressure that's falling. You're always at 21% oxygen. So this PiO2 here is 21% of this. So first we have to calculate this, all right? PiO2 is barometric pressure minus water pressure, which is 47 at body temperature, times FiO2. So how do you get barometric pressure? Well, you could look it up on an altitude chart, but up to about 10,000 feet or maybe 12,000 feet, you can estimate PiO2. And it's simply estimated by, for every 1,000 feet you go up in altitude, all right, your PiO2 drops 5 torr, or 5 millimeters of mercury. So in this case, PiO2 is going to be 150 minus 5 times x, where in this case x is 8,000 feet. So that's going to be 5 times 8 is 40. So the inspired oxygen tension is going to be 110 instead of 150. And as I mentioned, you can estimate this. This shows how close that estimate is. The red is the actual measured PiO2 at different altitudes. The green is that calculated by the 5 system, and really up to about 15,000 feet. This is very accurate. Beyond that, it underestimates what the PiO2 is. In this case, then, if we use the alveolar air equation, but now with the PiO2 110, minus 40 divided by zero point 0.8, the P alveolar O2 is going to be 60, right? Instead of close to 100. So PO2 of 60 gives you a saturation of 89%, all right? So the saturation will be 89%. And the correct answer to the question is a PO2 of 60. All right. As her physician, you are uncomfortable with a PO2 of 60 and a SAT of 89 at 8,000 feet elevation. You would like her SAT to be at least 95%. Perhaps she has pulmonary hypertension. What FiO2 should you choose to achieve a saturation of greater than or equal to 95%? And the choices are 23, 25, 28, 30, 35. So we're going to look at the saturation we want, right? 95%, which is a PO2 of 80. All right. So again, PiO2 over PaO2 is constant, right? Um, and so we basically can use this same relationship, all right, to look at the fraction of inspired oxygen that we want versus the actual, which is 21% at sea level. Well, I'm sorry, versus 21%, and at altitude, that gave you a PO2 of 60. We want to know what's required to give us a PO2 of 80. And so you simply solve for FiO2, which in this case is going to be 1.33 times 21% or 28%. And if we use 28%, we get an alveolar O2 at least of 97. So again, we're overdoing it a little bit, but at least we get adequate oxygenation. So the correct answer here, 28%. So let's summarize. So today what we've learned, or what we remember, is that gas exchange is dependent on VQ. A normal VQ ratio of 1 gives us a PO2 of 100 and PCO2 of 40. VQ greater than 1 gives you increased O2 compared to normal and decreased CO2 compared to normal. VQ less than 1 gives us decreased O2 compared to normal, increased CO2 compared to normal. Absorption atelectasis distal to complete airway obstruction. Okay, absorption atelectasis occurs rapidly, breathing 100% oxygen. It can occur breathing 21% oxygen, no more slowly. It can occur at any FiO2, but it takes longer at a lower FiO2. And decreasing FiO2 does not reduce the amount of absorption atelectasis. Absorption atelectasis with incomplete airway closure, that is, it's still open, can occur if alveolar gas is removed faster than is replaced. So the lower the regional VQ, the lower the FiO2 where collapse can occur. At a VQ of less than 0.001, absorption atelectasis can occur breathing room air. So VQ is more important, perhaps, at determining absorption atelectasis than FiO2. For pneumothorax, assuming there's no continuing leak, breathing an FiO2 100% facilitates absorption of oxygen and nitrogen from the pneumothorax to venous blood. It does not alter pneumothorax PO2 or PN2, but it decreases mixed venous PN2, creating a huge nitrogen pressure gradient from pneumothorax to venous blood, so gas moves in that direction, decreasing the pneumothorax volume. PCO2 is inversely proportional to VQ and VA. The alveolar air equation can be used to estimate P alveolar O2. All right, and there it is for you. Using supplemental oxygen, that is to increase it due to increasing FiO2, or at high altitude, decreasing PiO2 due to decreasing barometric pressure. Increasing FiO2 required to increase PO2 at a certain value can be calculated using the ratio of actual to desired P arterial O2. We're done with gas exchange for the moment, and next time we're going to move on to arterial blood gases and acid-base balance, and I think you'll find that we have an interesting and fairly easy way to deal with acid-base balance. Thanks again to our director-producer, Katie Lewinter, and thank you for joining us.